Thank you for joining today's Healthy People 2030 webinar titled Healthy People, Healthy Hearts, Healthy People 2030 and Cardiovascular Health. My name is Elizabeth D., and I'm a public health analyst within the Office of Disease Prevention and Health Promotion, or ODPHP. And ODPHP is within the U.S. Department of Health and Human Services and manages the Healthy People Initiative. Next slide, please. I'd like to welcome you to the fourth webinar of our Healthy People 2030 webinar series and the final Healthy People 2030 webinar for 2022. We look forward to covering additional Healthy People 2030 objectives and themes next year in 2023. Through our Healthy People 2030 webinar series, ODPHP, with the statistical expertise of CDC's National Center for Health Statistics, aims to feature the latest data on Healthy People 2030 objectives, including the leading health indicators, the overall health and well-being measures. And in each webinar, we feature states, communities, and organizations working to achieve the Healthy People 2030 targets through the implementation of evidence-based interventions, programs, and/or policies. You can join our Healthy People listserv at health.gov to stay informed about the dates and themes of the upcoming webinars. Next slide, please. During today's event, we will hear from Carter Blakey, Deputy Director of the Office of Disease Prevention and Health Promotion, who will present on the importance of the 4 Healthy People 2030 objectives featured in today's webinar and explore how these objectives relate to cardiovascular disease prevention and control. Following Carter's presentation, we will hear from Dr. Irma Arispe, who is the Director of the National Center for Health Statistics, Division of Analysis and Epidemiology. Dr. Arispe will provide details on current progress toward meeting the objective targets for the 4 Healthy People core objectives, and also review differences observed across population groups. Lastly, Shebra Hall from the Delaware Department of Health and Social Services will share details on their efforts to address adolescent obesity and prevent cardiovascular disease. Following these presentations, we will have a moderated Q&A with these speakers, as well as with 3 subject matter experts who represent the Healthy People 2030 topic area work groups that oversee today's featured Healthy People 2030 objectives. We encourage you all to submit your questions into the Q&A feature, which is located in the bottom right of your screen throughout today's presentations. And we will do our best to address as many of your questions as time allows. It is my pleasure now to transition the webinar over to Carter Blakey to provide the overview of today's theme and featured objectives. Carter.
Great. Thank you, Elizabeth. And many thanks to all of you in the audience who have joined us today. So I'll start things out with a brief overview of the Healthy People 2030 objectives that we'll focus on during today's webinar. So next slide, please. Oops, there you go. So today's webinar will feature 4 Healthy People 2030 objectives, which are listed here on the screen in alphabetical order by their Healthy People topic area work group. And these work groups that manage the objectives are made up of federal subject matter experts in the particular areas. So there are 2 objectives organized under what we call the heart disease and stroke topic area. And those are HDS2, which is reduced coronary heart disease deaths, and HDS3, reduced stroke deaths. And then from the nutrition and weight status topic area, we have NWS4, which is reduce the proportion of children and adolescents with obesity. And from the tobacco use topic area, we have TU14, which is increase successful quit attempts in adults who smoke. So these 4 objectives are what we call Healthy People core objectives, which means that they'll be tracked throughout the decade, and the progress toward achieving their targets will be updated on our healthypeople.gov site as the data become available. So included on the right-hand side of the slide are some additional characteristics of the core objectives, Again, as I said, they're measurable and they're associated with targets for the decade. They reflect high priority public health issues that are associated with evidence-based interventions. They have valid, reliable, nationally representative data, including baseline data from no earlier than 2015, and data will be provided for core objectives for at least 3 time periods throughout the decade to enable us to distinguish if there are any trends or not. And then one of the objectives, I'd like to point out, NWS4, reduce the proportion of children and adolescents with obesity, has been further elevated in Healthy People 2030 as a leading health indicator, and the leading health indicators, or LHIs as we call them, are a small subset of high priority Healthy People 2030 objectives that we've selected to drive action toward improving health and well-being. So next slide, please. So before we begin discussing the featured objectives, I think we all have to acknowledge that the COVID-19 pandemic has affected almost every part of our lives. And then as such, it's important to recognize that those impacts on the Healthy People 2030 objectives we're reviewing today, as well as for all the objectives across the decade. So the COVID-19 pandemic may have influenced the overall health trends in the United States and some of the issues covered in today's webinar. Then additionally, the pandemic has impacted measurement and data collection efforts for all our various data sources, including those used in Healthy People 2030. And then it's important to recognize that as the nation emerges from the COVID-19 pandemic, Healthy People 2030 will provide a foundation on which to frame an approach for recovery that results in a more equitable and resilient state than existed before the pandemic. So now let's review each of those objectives. So we'll move on to the next slide, please. And the first step is coronary heart disease. So heart disease is the leading cause of death for men, women, and people of most racial and ethnic groups in the United States. About 1 person every 34 seconds in the U.S. Dies from cardiovascular disease. Then about half, or some 47% of Americans, have at least one of 3 key risk factors for heart disease, and that would be high blood pressure, high cholesterol, and smoking. Then of the different types of heart disease, coronary heart disease is the most common type of heart disease, killing some 382,820 people in 2020. So understanding the factors, including social determinants, that influence coronary heart disease death can help identify programs and policies to reduce coronary heart disease and deaths and promote health equity. For instance, creating healthy food environments and healthy recreational environments can create opportunities for a healthy diet and increased physical activity, which can promote lower blood cholesterol levels and help maintain normal blood cholesterol levels. So additionally, resources like the Centers for Disease Control and Prevention's, of CDC's, Best Practice Guide for CVD Prevention describes and summarizes scientific evidence behind 8 effective strategies for lowering high blood pressure and cholesterol levels that can be implemented in healthcare systems and then involve community clinical links. So it's critical to support action at the individual, community, and systems levels to promote opportunities for improved cardiovascular health. So next slide, please. So next up we have stroke. So stroke is the 5th leading cause of death in the United States and a leading cause of long-term disability. So low-income populations, some racial and ethnic groups, and people who live in certain geographic regions are more likely to have a stroke and die of a stroke. So like coronary heart disease, interventions to lower people's risk for stroke by improving blood pressure, diet, and physical activity are critical for reducing stroke deaths. Then raising awareness of stroke signs and symptoms and improving stroke management can also help reduce death and disability related to stroke. So the CDC has communication materials to promote knowledge of stroke signs and symptoms and the importance of FAST, or F-A-S-T, when that's face drooping, arm weakness, speech difficulty, and time to call 911, the fast response during a stroke and stroke treatment. Then additionally, many common medical conditions, including obesity, can increase one's chances of having stroke. Addressing obesity early in life can help make improvements in the two areas discussed today, that's strokes and coronary heart disease deaths, by encouraging a healthy, active lifestyle across the entire lifespan. And during today's webinar, we'll also explore child and adolescent obesity as measured by that NWS objective on obesity. So next slide, please. So this is the third objective that we'll discuss today, and it's the one that's also a leading health indicator. So there's a critical need to address obesity, which puts individuals at an increased risk for many serious diseases and health conditions compared to individuals with a healthy weight. So in addition, obesity and its associated health problems have a significant economic impact on the U.S. healthcare system. So many factors can contribute to excess weight gain, including behaviors, genetics, and taking certain medications. But societal and community factors also matter, like childcare, school environments, neighborhood design, access to healthy, affordable foods and beverages, and access to safe and convenient places for physical activity all affect our ability to make healthy choices. And developing and promoting guidelines on dietary patterns and amounts of physical activity, Americans need for a good health status is a key step that the federal government takes to help address this important issue. And the implementation of these guidelines at state and local levels is necessary to ensure that communities, environments, and systems actually do support active, healthy lifestyles. Then in just a bit, we're going to hear from Shebra Hall of Delaware's Health Department about their efforts to address child obesity. So next slide, please. So the final objective we'll discuss during today's webinar is tobacco cessation. So tobacco use is the leading cause of preventable death, disability in the United States. Smoking is a major cause of cardiovascular disease, and smoking and secondhand smoke exposure cause 1 in every 4 CVD deaths. Now, quitting smoking reduces the risk of disease and death from cardiovascular disease and also benefits people who already have coronary heart disease. Then in 2012, CDC launched the first federally funded national tobacco education program, which is called TIPS, from former smokers, or TIPS for short. So TIPS ads tell the stories of real people living with serious long-term health effects for smoking and secondhand smoke exposure, including cardiovascular disease. So TIPS aims to encourage people to quit smoke and connect them to free resources to help them quit, like this number, which is 1-800-QIT-NOW, NWO. So CDC estimates that from 2012 to 2018, more than 16.4 million people who smoke attempted to quit, and approximately 1 million successfully quit because of the TIPS campaign. So the TIPS campaign uses approaches to address health disparities and advance health equity by increasing the reach, representation, receptivity, and accessibility of smoking cessation messages. So reducing resources like this are instrumental in helping all population groups reach the National Healthy People 2030 target. So I know that was a brief overview, but now I would like to turn the webinar over to Dr. Irma Risby, who will give us a detailed account of the data for these 4 Healthy People 2030 objectives. So Irma, the stage is all yours.
Thanks, Carter. Could I have the next slide, please? I'm pleased to be here with you today to share data for the 4 Healthy People 2030 objectives chosen to frame our discussion on cardiovascular disease prevention and control. As Carter mentioned in her presentation, the measure on child and adolescent obesity I'll discuss today is a leading health indicator, or LHI. The other 3 measures I'll cover track coronary heart disease, stroke deaths, and successful adult smoking cessation attempts. Next slide. I'll begin by discussing coronary heart disease deaths. Next slide. Coronary heart disease death rates are tracked annually with death certificate data from the National Vital Statistics System. A coronary heart disease, or CHD, mortality objective has been included in the Healthy People Initiative since Healthy People 2000. Next slide. This slide shows trends in CHD death rates between 2007 and 2021 for the total population and by sex. The data for 2021 are provisional, and final data will be available later this month. Between 2007 and 2021, the age-adjusted rate of CHD deaths declined by 26% among males and by 37% among females. While CHD death rates declined steadily through 2019, there was an increase in 2020 and then a decline in 2021. There is a disparity between males and females in CHD deaths, and it has increased over time. In 2007, the rate of CHD deaths was 71% higher among males than females, and in 2021, the CHD rate for males became twice as high as that for females. Next slide. This slide shows disparities in CHD death rates for selected demographic groups in 2020. Now, throughout my presentation, when discussing race and ethnicity, we'll look at Hispanic ethnicity along with racial groups, all of which exclude persons of Hispanic origin. Compared to the groups with the most favorable rates, the CHD death rates were more than twice as high for the Black population, never married and divorced or widowed adults, and for adults with less than a high school or high school education. Next slide. The map here shows CHD death rates in the period from 2018 to 2020 by county of residence. Death rates vary by region. Counties with lower rates are shown in green and light blue and are located in the West, Upper Midwest, Alaska, and Hawaii. Counties in green met the national target. The highest rates, shown in the darker blues, were observed primarily in the upper portions of the South, from Texas to West Virginia. Next slide. I'll now discuss stroke deaths. Next slide. Stroke deaths are tracked with death certificate data from the National Vital Statistics System, and a stroke mortality objective has been included in Healthy People since Healthy People 2000. Next slide. This slide shows trends in stroke death rates between 2007 and 2021 for the total population and by sex. Between 2007 and 2013, the rate of stroke deaths declined for both males and females. This was followed by an increase between 2013 and 2021, with the largest increase between 2019 and the first year of the pandemic, a 5% increase overall. Compared to death rates for CHD, stroke death rates among males and females show much less disparity. Next slide. This slide shows disparities in stroke deaths in 2020. Compared to their counterparts, the stroke death rates were highest among the Black population, divorced or widowed and never married, among adults with less than a high school or high school education, and among those living in non-metropolitan areas. The largest disparities were by educational attainment and marital status. Next slide. This map displays stroke death rates in the period from 2018 to 2020 by county of residence. Death rates again varied by region, with clusters of lower rates shown in green and light blue in the mountain, north central, and northeastern United States. Counties in green met the national target. The highest rates, which are shown in the darkest blue, were observed in the southeastern United States in a region generally referred to as the stroke belt. Next slide. I'll now turn my attention to child and adolescent obesity, which is an important risk factor for cardiovascular disease. Next slide, please. Obesity in children and adolescents aged 2 through 19 years is defined as a body mass index at or above the sex and age-specific 95th percentile from the 2000 CDC growth charts. Height and weight data are measured in the physical examination component of the National Health and Nutrition Examination Survey. Next slide. This slide shows trends in child and adolescent obesity rates between 2001 and 2004 and 2017 to March 2020 for the total population and by age group. During this period, the obesity rate increased by 30% among children aged 6 through 11 and by 19% among adolescents aged 12 to 19. Among children aged 2 to 5, the obesity rate increased 23%, beginning with the period from 2009 to 2012. Next slide. In the next two slides, we'll look at child and adolescent obesity in the 2017 to March 2020 time period by subgroup. Boys and girls had a similar rate of obesity. However, there were differences in obesity by ethnicity and race. The obesity rate for Black and Hispanic children and adolescents was more than 2.5 times as high as the rate for Asian children and adolescents. Next slide. Compared to the groups with the most favorable rates, the obesity rates were twice as high among children and adolescents from families with incomes below and between 100 and 199% of the HHS poverty guidelines, and similar disparities are seen for those without health insurance. There were no significant differences by country of birth. Next slide. Finally, I'll talk about smoking cessation among adults. Next slide. Specifically, we'll be looking at our measure of recent smoking cessation success among adults. This is defined as adults aged 18 or over who report ever smoking 100 cigarettes and who last smoked 6 months to 1 year ago. Next slide. In the next two slides, we'll take a closer look at disparities in recent cessation success among U.S. adults. In 2020, white adults had the highest rate of recent smoking cessation success, which was nearly 2 times the rate of Hispanic adults, the group with the lowest rate. Rates of smoking cessation success increased with increasing levels of education among adults aged 25 years and older. The rate for adults with a 4-year college degree or more was 2 times the rate for adults with less than a high school education. Next slide. On this slide, we see that adults with health insurance had higher or better rates of recent cessation success compared to those without health insurance. Younger adults, ages 18 to 44, had rates that were about 2 times higher than those in the older age groups. Next slide. This slide shows the percent of recent smoking cessation success in the U.S. from 2008 to 2020. This objective is tracked with data from the National Health Interview Survey, which was redesigned in 2019. Data before and after the redesign have not been fully evaluated for comparability, and therefore we're showing a break in the trend between 2018 and 2020. The percent of recent smoking cessation success increased over the Healthy People 2020 tracking period and begins the Healthy People 2030 initiative at 8.5% in 2020. Next slide. So I'll end by sharing some key takeaways. Next slide. After a brief increase in 2020, CHD death rates continued their long-term decline. In contrast, stroke death rates have generally been increasing since 2013, especially in 2020. The largest disparities were by race and ethnicity, marital status, educational attainment, and geographic area. CHD mortality for males was twice as high as for females, while differences in stroke mortality by sex were comparatively similar. Child and adolescent obesity rates continue to increase. There were disparities by race and ethnicity, family income, and health insurance. And finally, in 2020, less than 1 in 10 adult cigarette smokers reported that they had recently successfully quit smoking. Next slide. So thank you, and I'd like to thank and acknowledge the 4 work groups whose objectives were highlighted today, as well as the NCHS and ODPHP staff listed here for their contributions. Now I'll turn it over to Shibra, our next speaker. Thank you.
Good afternoon, everyone. I'm Shibra Hall from the Delaware Division of Public Health, and I'm the Program Administrator of the Physical Activity, Nutrition, and Obesity Prevention Program, or PANO for short. And PANO is in the Health Promotion and Disease Prevention section of the Division of Public Health, and we have multiple programs in our section that address and promote cardiovascular health as well as obesity prevention. But today I'm going to talk about the work of a PANO initiative advancing healthy lifestyles, chronic disease, health equity, and COVID-19, or AHL for short, and the activities that we are engaged in as part of AHL that address some of the Healthy People 2030 objectives that we're talking about today, specifically to reduce the proportion of children and adolescents with obesity. Next slide. But before I talk about the health objectives, I would like to share a little about Delaware and our public health agency. So Delaware Division of Public Health is a part of Delaware's Department of Health and Social Services and serves as the state's public health agency. DPH is nationally accredited, recognized by the Public Health Accreditation Board for demonstrating commitment to quality improvement, performance management, accountability, transparency, and ability to address public health needs. DPH covers the 3 counties of Delaware, Newcastle, Kent, and Sussex, or a small state, and serves as the center of a comprehensive network of public health services, establishing public health priorities and evaluating the effectiveness of health initiatives. And the mission of DPH is to protect and enhance the health of the people of Delaware. Next slide. So we heard some information about these different Healthy People 2030 objectives. And so I just want to share a little bit about what we're doing here in Delaware before I focus in on childhood obesity. So for the objectives to reduce coronary heart disease deaths and reduce stroke deaths, the Division of Public Health hosts the Diabetes and Heart Disease Prevention and Control Program. The goal of the Diabetes and Heart Disease Prevention and Control Program is to decrease the state's emotional, physical, and financial burden from diabetes and heart disease by preventing the diseases and reducing their complications. The program supports community clinical linkages, health systems interventions, and epidemiology and surveillance. The program collects and publicizes current information about diabetes and heart disease, develops approaches for reducing the impact of the diseases, and coordinates efforts of public and private health organizations. For example, the Diabetes and Heart Disease Prevention and Control Program supports the Million Hearts Initiative, which is a national initiative from the Centers for Disease Control and Prevention and the Centers for Medicare and Medicaid Services that promotes the implementation of evidence-based strategies to prevent cardiovascular disease. And Target BP, which is an initiative from the American Heart Association and the American Medical Association that serves as a response to the high prevalence of uncontrolled blood pressure. The program also has a mobile diabetes and hypertension wellness initiative, which is a program that identifies individuals at high risk for hypertension and/or diabetes within the worksite setting. They also facilitate a robust social marketing campaign that leverages national media efforts as well as develops local campaigns that promote healthy lifestyle habits for chronic disease prevention and control. Next slide. And as we heard earlier, tobacco use remains the #1 underlying cause of premature death and disability here in Delaware. The DPH works to prevent the use of tobacco products and address the objective increase successful quit attempts in adults who smoke through its Tobacco Prevention and Control Program. The Tobacco Prevention and Control Program supports the Delaware Quit Line, the only quit line in the United States to offer a face-to-face counseling option, which has served more than 65,000 people since its inception in 2001. Updated services include vaping cessation for youth age 13 and up, and combination therapy for those with behavioral health conditions. The program also works with healthcare providers across the state. They offer healthcare providers education packets to inform them about the quit line, and partner providers have adopted the 2A's and R protocol, where they ask about smoking, advise to quit, and refer to the quit line. They have also developed various social marketing and media campaigns that are tailored to populations experiencing tobacco-related disparities. Campaigns have included focus on cigars, menthol, vaping, exposure to secondhand smoke, and cessation. Audiences are reached through television, radio, outdoor ads, and social media. The program has also awarded many grants to over 130 organizations statewide since 2003 to implement tobacco prevention and cessation activities in their communities. Next slide. And again, we heard what obesity looks like, or childhood obesity looks like across the country, but I want to share with you what childhood and adolescent obesity looks like here in Delaware. Despite our efforts, childhood obesity is still of great concern in Delaware, as it is across the country. The Division of Public Health conducts the School-Based Youth Risk Behavior Survey, or YRBS, of Delaware public high school students. And in 2021, 17% of Delaware public high school students reported BMIs considered obese. Male students at 20.6% have a higher obesity prevalence than female students at 13.2%. Prevalence is slightly higher among Black or African American students at 24.3% than Hispanic students at 18.5%, or white students at 11.9%. Another 15.4% of Delaware public high school students report being overweight but not obese. That means 32.4% of Delaware high school students reported being either obese or overweight in 2021. Next slide. We can break that down by ages. In Delaware, among high school students who were between 12 to 15 years old, 17.3% reported being overweight and 18.5% reported being obese. Among high school students who were 16 years old, 14.6% reported being overweight and 20.5% reported being obese. And among high school students who were 17 to 18 years old, 13.4% reported being overweight and 12.3% reported being obese. And we know that the Centers for Disease Control and Prevention recommends children and youth get at least 60 minutes of physical activity a day on at least 5 days of every week. However, according to the 2021 YRBS, in Delaware, among high school students, 19.6% reported not participating in at least 60 minutes of physical activity on at least one day, and only 21.6% of high school students reported being physically active for 60 minutes for all 7 days. So youth overweight and obesity prevalence is still too high, and it's a serious public health issue, putting children and adolescents at risk for poor health. Next slide, please. So what are we doing to address childhood obesity, or more specifically, Healthy People 2030 objective, reduce the proportion of children and adolescents with obesity? Well, in 2021, the Division of Public Health PANO program launched the Advancing Healthy Lifestyles Initiative. The Advancing Healthy Lifestyles Initiative, or AHL, has two key goals: reduce obesity and other chronic conditions, and to work towards achieving health equity for all Delawareans. The AHL initiative has three fundamental component areas: coordinated school health and wellness, where we focus on our youth at school and community partnerships; community capacity building, where we leverage our partnerships to support community-based organizations and the work that they're doing; and employee health and workplace wellness, which, like all of these efforts, are part of Delaware's plan to improve health and wellness for all Delawareans. So as I continue this presentation, I will describe how we are addressing Healthy People 2030 objective, reduce the proportion of children and adolescents with obesity through our work in the Advancing Healthy Lifestyles Initiative, an AHL. And under each component of AHL, we have multiple initiatives going on and all at different stages of implementation and data collection. But I'm going to focus my presentation on the school and community components of AHL. Next slide. So the AHL initiative is supporting the implementation of the Boys and Girls Club national program called Triple Play. And the goal of this healthy lifestyle program is to promote the importance of physical activity and proper nutrition through the three components of a healthy self: mind, body, and soul. Triple Play is a national Boys and Girls Club program, meaning the Boys and Girls Club of America provides the healthy lifestyle curriculum for the Delaware sites to follow. The goals of the program are to improve participants' knowledge of healthy habits, good nutrition, and physical fitness, to increase the numbers of hours per day they participate in physical activities, and to strengthen their ability to interact positively with others and engage in healthy relationships. Youth who participate in Triple Play report double-digit increases in physical activity, improved eating habits, and improved relationships with their peers, which have all been linked to positive long-term health outcomes. Next slide. I also want to share a little bit about some of the Triple Play program participants. So Wowzers are a teen workforce initiative run by the Boys and Girls Club of Delaware. These workers, known as Wowzers, are hired and trained to run programs and lead lessons for younger club members. After 2 trainings and 8 sessions working with the younger members, the teen members receive a stipend. And Wowzers gives these hardworking teens an opportunity to fit valuable job experience into their busy schedules and enables younger members to participate in enrichment activities. Including Wowzers in the delivery of Triple Play positions the teens to model behaviors covered in the curriculum for younger students. In addition, student interns from local universities and colleges provide extra adult supervision during these afternoon hours. Next slide. So a little about implementation and some context on the Delaware landscape. The goal was to implement Triple Play at one school in each of Delaware's 3 counties, taking into consideration that each county has its own characteristics, strengths, and challenges with both urban, rural, and diverse populations. With those considerations in mind, Pano and the Boys and Girls Club selected the school locations based on those that they felt had the most capacity to take on the Triple Play programming, and that could benefit the most from this work. So the pilot program began in the spring of 2022, so last September, at 3 elementary school sites, 1 site in each county. And this consisted of 2 10-week sessions. Session A for 10 weeks from January to March, and Session B ran from March to May. Each session consisted of an introduction orientation week and then 8 weeks of direct Triple Play programming once per week at an end of session celebration for the students. Over the 2 cycles, 148 youth participated in the Triple Play program across the 3 locations. In the summer of 2022, we used 3 different sites: 2 elementary schools and a Boys and Girls Club location instead of a school location. And this was in Rehoboth Beach, which is in Sussex County, Delaware. And for context, Sussex is the most rural part of the state. Transportation tends to be a challenge for many families. So it was determined that a club site would work best for over the summer for this area. So programming ran 3 times per week from June to August, and over the summer we had 253 youth participate in Triple Play programming. In the fall of 2022, we implemented Triple Play in 6 elementary school sites with 2 sites in each county, and we will be running the program over 3 9-week sessions. So Session A was this past September to November, Session B will be January to March, and C will be March to May. Next slide, please. This demographic data is collected by the Boys and Girls Club when youth are enrolled in any programming with the Boys and Girls Club, but here we have included the demographic data from the spring and summer sessions combined for each county, and there were 401 total participants. Next slide. So thinking about our data sources, for youth with parent consent, data collection included a 3-question survey or exit ticket at the end of each lesson. In addition, youth complete a final short post-program survey at the end of session celebration. We also collected data from the Wowzers. The team collected both teen assent and parental consent before participation. For the teen participating as Wowzers, our team administered a brief online pre-program measure before the first triple play activity, and a post-session survey was administered within 1 week of the final activity. Survey questions focus on teens' overall experience and potential skill gains, for example, things like leadership and community building. So now the image you see on the left is an example of what the exit ticket looks like for the youth participants. Each exit ticket included questions related to the goals of the individual lessons, with different faces representing the response options for yes, no, or maybe. Youth completed the exit ticket on paper, and the site coordinators then entered the information electronically. The chart on the right is a summary of the data collected from that session's exit tickets. The goal of the brief weekly assessments was to enable the evaluation team to capture data at the conclusion of each lesson when the memory of the experience was still fresh in the youth's minds. Next slide. A final short post-program survey was designed for administration at the end of session celebration. For example, after participating in the triple play program for the summer session, 65% of youth in grades K through 2 reported that they had a better understanding of why it is important to eat healthy food, and 50% of youth grades 3 to 5 said the same. Regarding physical activity and movement, 60% of youth in grades K to 2 reported they had a better understanding of why it is important to move their body, and 58% of youth in grades 3 to 5 said the same. Next slide. Here are some additional examples of the types of questions that the post-program survey provided. Of participants in grades K to 2, 68% said they learned new information about food, and 47% of participants in grades 3 to 5 learned new information. Of the participants in grades K to 2, 74% said they learned new information about moving their bodies, and 55% of participants in grades 3 to 5 learned new information. Next slide. So we had some lessons learned. We did experience some challenges with implementation and evaluations at first. During the initial spring pilot session, we had to ask parents for permission for their youth to participate in the triple play evaluation processes. So for the summer 2022 sessions, we built consent into the Boys and Girls Club registration for triple play participants so that all paperwork was collected at the same time. This approach reduced the need for us to go back to parents a second time to obtain permission to participate in the evaluation processes. We also saw that during the spring session, the Boys and Girls Club were entering data into a Google form. However, we determined that entering the data into an Excel spreadsheet would be less burdensome than using Google, and adopted this process for summer of 2022. The site directors completed the spreadsheets weekly in SharePoint, a document sharing platform, so that data and data entry was monitored regularly. By the summer of 22 session, we also instituted an orientation into the evaluation process and activities for the Wowzers to expose them to the data collection tools and help them to understand the importance of data collection. We also had some conflicting priorities for the Wowzers. We had to align the program schedules to accommodate their other activities, like school sports, for example, to help increase the number of Wowzers participants. The Wowzers are high school and college age students. Many are athletes and have other commitments. So we adjusted the start of triple play programming so it's not the same as heightened activities at schools when and if possible. Some other challenges that we face, like what's happening across the country, but especially in youth serving organizations, the Boys and Girls Club has faced challenges related to staffing. Turnover in child care and after school care has been exacerbated due to the pandemic and staffing shortages in general in the field. And of course, COVID-19 continues to have an impact on attendance and participation, particularly for the staff. Next slide. So for some additional uses of the data, we can use the data collected to help with program and process improvement, as well as decision making as we move forward and continue with this work. With over 200 triple play lessons, the plan is to use the exit tickets to help us identify the most effective lessons and to help make some determination on which lessons should be used in the future. Exit tickets can help us determine if we're delivering the right kinds of lessons at the right time. And for dissemination, just thinking about the goal is not to just collect data for the sake of collecting data. We want to share the data in our program implementation process more broadly. We want to consider the content that can be shared on social media from the Boys and Girls Club as well as from public health. We created a document brief summarizing the program. We'll continue adding to this now that we have some data to include and to share. We want to create infographics and visual representations on program data that we've collected so that we can share as well. We recently hosted a webinar where we shared our triple play implementation process. We had presenters from the program administrators from the Boys and Girls Club of America, as well as Delaware, as well as a Wowzer. We had a teen provide his perspective on the experience, which was really neat to hear from. Next slide, please. So briefly, I'll just go through, let's see. In addition to our school and community partnerships, one of AHL's component areas is community capacity building. And through AHL, PANO is supporting community partners by providing technical assistance with planning and implementation of their community-based interventions. So we're currently working with Delaware State University, the University of Delaware Cooperative Extension, and the American Lung Association to work on projects including nutrition education, physical activity, and lung health. Next slide. And finally, through AHL, PANO has also awarded 8 mini grants to additional community partners. The purpose of the mini grant program is to support Delaware community organizations with projects that improve community health and reduce chronic disease through policy systems and environmental approaches using a health equity lens. These 8 mini grant recipients were selected from a large pool of applicants as part of the first AHL mini grant proposal cycle. And some examples of projects addressing some of the Healthy People 2030 objectives that we focus on today include promoting physical activity and walking programs in schools, the workplace, and in the community, educational opportunities on a mini farm, a robotic garden, a community garden, nutrition education and food preparation classes, and the recipients are from a variety of different local nonprofit organizations, including municipalities, churches, the Breast Cancer Coalition. So we're really excited about this work. Next slide, please. And here I just have some links for you for the activities I talked about today, specifically the Advancing Healthy Lifestyles Initiative. So I invite you to visit the AHL website to learn about what we're doing, check out our document briefs on these activities, and on the next slide is my email address. If you contact me, I'd be sure to connect with you on how you can get some more information. Thank you so much for this opportunity to share what Delaware is doing to address some of the Healthy People 2030 health objectives. Thank you.
Thank you, Shebra, and thank you to Carter and Irma for your fantastic presentations. We will use the remainder of our time together today for a moderated Q&A session. So at this time, I will ask all of our presenters, as well as our Healthy People 2030 work group subject matter experts, to turn on their cameras so we can have some face-to-face discussion. As folks are doing that, I will quickly note that several slides with resources recommended by our Healthy People 2030 work group subject matter experts will circulate on the screen as we go through our discussion for moderated Q&A. These are available and will be viewable for your reference. So with that being said, let's go ahead and dive into a series of questions that we've already gathered for folks. And I will actually start with Carter. Carter, we received a question inquiring about how folks may be able to partner with Healthy People 2030 in the space of reducing cardiovascular disease, but I also will kind of broaden the question to generally for any of our objectives for healthy people as well.
Right.
What might be an opportunity?
Gosh, that's a perfect question to receive. Well, the first point I'll make is that we do have the Healthy People Champions program, and this is a partnership program where organizations who share our vision of improving the health and well-being of all Americans across the lifespan can join with us officially as partners. And I think someone might be able to put the link in the page, in the chat. But anyway, and I think we also have a slide. I think we might have a slide that has the Champions programs. That would be perfect. But anyway, we encourage folks to partner with us with the Champions program that gives you an opportunity to network with like-minded organizations from across the country. Also, we have different tools and resources for champions, whether they're champion-specific webinars where we do feature what others are doing, whether it's a state or local health department, a private company, an academic or research organization. So anyway, that's one way. And then just going to our website and checking out the various resources for the specific objectives. And if you were to go to the website and find our heart disease and stroke objectives, there are resources or evidence-based resources that you can use. But anyway, those are a couple ways. And of course, look at our social determinants of health framework, because that really emphasizes the importance of working with partners, not only within our traditional health sector, but beyond. So you can get ideas on how to broaden your horizons in terms of improving health. So anyway, those are a few quick ideas.
Perfect. Thank you so much, Carter. I do have a question next for Irma. And Irma, during today's presentations, the influence of the pandemic on data collection was briefly touched upon, but wondering if you can speak more about how the pandemic has affected the ability to track these healthy people objectives that we're featuring.
Yes, thank you, Elizabeth. So the effect of the pandemic was very different depending on data systems. So for example, the mortality data we presented come from death certificate data, and those data were not substantially affected by the pandemic. In fact, during the pandemic, we were able to release early estimates on a weekly basis that tracked mortality, including cardiovascular mortality, to look at the larger effects of the pandemic. So those data were not really affected as far as we can tell. In contrast, the National Health Interview Survey is a survey of people where we go to their homes and conduct the interview. And that survey was affected both by the redesign that we did in 2019 before the pandemic and the pandemic itself. So in 2020, when the pandemic took hold, we pulled out of the field and incorporated a phone component. And so right now we're looking at both the effects of the redesign and the telephone mode of operation and the response rates to see how data will be affected over the decade. And the data system that was affected the most was the National Health and Nutrition Examination Survey. So in that survey, we conduct interviews and individuals come to mobile examination centers. So they actually come in for a physical examination. And that survey had to be paused for COVID concerns in March of 2020. So what we did was, in order to produce data pre-pandemic that were nationally represented, we combined 2017 through March 2020 for our first data reporting period.
That's really helpful, Irma. Thank you so much. I'm looking at the next question here, and this one is for Shebra. The next question for you is regarding the PANO program that you just presented on. Curious if you can share more about how and why the Physical Activity, Nutrition, and Obesity Prevention Program started the Advancing Healthy Lifestyles Initiative.
Sure. So the PANO program is in a position in the state to work with some decision-making bodies that can really get things done. And we actually partner with the Delaware Cancer Consortium, and they were tasked by the governor in 2019 to develop some policies, recommendations that are addressing health and wellness for birth to 18, as well as some other initiatives. And so that's what we did. We came up with a healthy lifestyle subcommittee and really put, during the middle of the pandemic, we really started working towards some, thinking of some policy recommendations that could impact the health and wellness of children. So at the same time, we decided to launch this, a request for proposal where we can get some help in figure out a way to align our efforts with the state as well as with the policy recommendation work. So it all kind of came together with this initiative, starting from the governor's blessing. So really fortunate.
Absolutely. Thank you so much for answering that question. The next question here is from Maya. Maya, we're honored to have you on as our SME on the tobacco use work group. In addition to the Quit Now telephone counseling service that Carter mentioned in her presentation, what are some additional evidence-based cessation services that offer support to help people who are trying to quit?
Question. So absolutely, that evidence-based treatment, behavioral counseling, and FDA-approved cessation medications can help successfully quit, particularly when counseling and medications are used together. So quit lines are an evidence-based treatment. Every state has a quit line, which people can reach by calling 1-800-QUIT-NOW to be connected to free and confidential help to quit. And some quit lines also offer medications. So web-based and texting-based services are also evidence-based resources to help people quit. Web-based resources include cdc.gov/quit and smokefree.gov. And there's a new national texting portal that connects adults in the U.S. with mobile text message-based support to help them quit smoking. So this free support includes encouragement, advice, and tips for becoming smoke-free in either English or Spanish. So to enroll, adults can text Quit Now or Déjalo Ya to 333-888 for English or Spanish. And evidence-based texting services are an important complement to 1-800-QUIT-NOW, since texting services may reach people who want additional quit support, but may be less likely to call a quit line.
Thank you so much. And I see that the timing was excellent. We do also have additional resources on the screen right now too related to this particular Healthy People objective. So thank you for your answer to that. Deb, who is also a work group SME on our childhood obesity objective. Question for you about what are different population strategies that can be used to address childhood obesity? I know we heard a few today, but curious for additional thoughts from you.
Sure. So in addressing childhood obesity, we think both of prevention for children, so preventing them from having obesity, and then also treatment. And then in the prevention realm, we think about the different places where they interact with either diet, physical activity, or other behaviors. And that might include the child care setting, schools, and the community. And it might include things like policies and practices such as child care licensing. It might include curriculum. It might include quality improvement programs in child care. So a variety of options can be used. And the second place then is in terms of treatment, and we think in the healthcare setting, and that's ensuring that children who are identified as having obesity have access to the types of treatment programs that we know are evidence-based, based on the clinical preventive services. And these are intensive behavioral programs that last for many weeks, include many hours of curriculum that allow families to address physical activity and nutrition. We also know that part of that and getting those programs going is also thinking about making sure that healthcare is reimbursed for them and that we can document that they're happening. So it's thinking about codes in the EHR and some of the reimbursement issues there. Over.
Thank you. Thank you so much, Deb. And Mike, with the minute that we have left as our work group subject matter expert on heart disease and stroke, wondering if you could share a little bit more about why we see in the trend chart that Dr. Rispe showed, why coronary heart disease deaths increased between 2019 and 2020, and then we saw a decrease again in 2021.
Sure, I'd be glad to mention that. I believe a lot of it is related to really fear of COVID-19. People in 2020 were very hesitant to dial 911 or go to the emergency room, whereas by 2021, things started to go down a bit in terms of the age-adjusted mortality, a little bit from 2020, but still higher than 2019. I think the reason things improved is vaccines were at least part of it. But the first 4 to 5 months of 2021, we started to see vaccines fairly widely available to anybody who wanted one. So I think maybe that's why things did improve as far as CHD mortality 2021 compared to 2020.
Thank you so much. And I know that we could spend a lot more time talking about all of these important factors to cardiovascular health. I acknowledge that we are right up upon our time and appreciate you all joining our webinar today. This concludes our webinar. We will, at a future time, have the recording available so that you all can review this webinar as well as share it with your colleagues who maybe weren't able to attend today. So I want to thank all of our presenters, all of our speakers for presenting today, sharing your expertise, and we hope that you all will circle back with us for our next webinar series in 2023. So thank you all for attending. That concludes today's webinar.